Good afternoon and welcome to today's Link Senior webinar. Just a few housekeeping items before we begin today. To be eligible for the NAV and NCAP CEU credit hours, you must stay on the webinar for the full hour. At the end of the webinar, I will be providing the required post-webinar survey evaluation link in the chat box in the webinar room, and also by a constant contact email message. So be sure to check your spam box just in case it doesn't go to your primary inbox. You must fill out the survey no later than midnight this Sunday, October 21st, to be eligible for the CEU credits, and we will send out the certificates this coming Monday. So Link Senior has been providing these informational webinars since the beginning of this year, actually, and more than 2,000 people have participated so far. Here is a look at some of our past speakers, and you'll also see a quote from a webinar participant on the bottom of the screen. We're always looking for feedback from each of you, so if you have an idea for a future speaker, please email us at the address on this slide in the upper right-hand corner. Link Senior currently has more than 300 clients in the United States and Canada, and this slide just provides a snapshot of some of our partners and supporters. Today, we are thrilled to share some exciting new research results about resident engagement. These results come from our partnership with Responsive Management in Toronto and Western Oregon University. This is all with generous funding from the Baycrest-led Center for Aging and Brain Health Innovation, also known as CABHI. Here's a look at today's agenda as well as the objectives. We will be reserving time at the end of the webinar for your questions, so be sure to post those in the chat box in the webinar room, and we will ask them to the speakers at the conclusion of the webinar today. And some brief introductions here. We are excited to have Programs Manager Abiola Awosanya from Toronto with us today. Abby has been working in the field of recreational therapy for 10 years, and she has played a key role in the last year of research at Responsive. Unfortunately, Marion, Godoy, Senior Nurse Consultant at Responsive, will be unable to join us this afternoon, though Abby will be helping us out on her slides. Marion has been a key contact at Responsive for our research, and we are deeply grateful for her support of this project along with her team. We also have Dr. Ethan McMahan, Professor of Psychology at Western Oregon University with us. Ethan has been conducting the data collection and analysis from our 3 research sites over the past year, and he's going to be sharing some key takeaways today from his findings thus far. And last but certainly not least, we have Charles D. Villemorn, the CEO of Link Senior, who will now provide a brief introduction before we jump into the presentation on research results.
Thank you very much, Megan, and welcome everyone. Good afternoon for some of you, good morning for the others. It's a pleasure to share with you some of the preliminary results of the study. And what we thought we would do is explain to the audience the goal of our work today in 5 simple points, which is basically the background and why we need better evidence behind this broad field called resident engagement, right? Which covers, as a number of terms, anything related to therapeutic recreation or rec therapy, activities, wellness, or life enrichment. I'm sure that most of you are well aware of the work of Abraham Maslow. He is the one that came up with the pyramid of needs. And one of his most famous quotes is about the fact that each human being has their own individuality throughout the lifespan. Therefore, a musician must make music, an artist must paint, a poet must write, and so on. And we think that the most important part of this is that it's fundamental to understand person-centered care in senior care and how us as resident engagement professional can help keep people engaged in a person-centered manner and therefore increase their quality of life as much as possible. So the first point is that the fact that person-centered care is important, is one of the fundamental aspects of our field. The second aspect is, as we know, a lot of residents, a lot of our older adults that we serve today are dependent to stay engaged. And when you look at research, the basic definition of engagement is how you help, how you support, how you get somebody, an older adult, engaged, occupied in something that would drive their quality of life. That's the second aspect. The third aspect is how difficult our work is. If you look at the typical job description of a therapeutic recreation manager or an activity director, it would be difficult to imagine how this can be done all the time, right? We understand now when we look at these metrics on this slide now that we're not staffing much compared to the amount of residents we usually serve. As we know, most of these residents, because of different reasons, but mostly because of mild cognitive impairment or a diagnosis of dementia of some sort, cannot self-recreate. Sadly enough, in the middle, we now know that the family doesn't visit much. Therefore, the residents are very reliant, very eager to get the support from the staff to stay engaged. And we often forget that over-medication also gets in our way. This is the statistics for the antipsychotic drugs, but we now know that through evidence that things such as antidepressants, sleep medication also makes the engagement of the residents more difficult. Now, as a staff member, when I started Link Senior, I certified myself as an activity director. As a staff member, it's always important to remember what it is that we try to do as a professional. And that is simply, we want to engage the residents by knowing who they are, right? Remember this idea of person-centered care. We want to be able to plan accordingly based on who each individual is and what they need and so on. We want to be able to engage them, and then we want to be able to evaluate, therefore have an understanding of if our work was successful or not. Until we do that, and when we do that, this is how we help meet the needs and the preferences and support the purpose of each and all of our residents, the older adult that we serve. As you saw from the previous slide, before that I scanned quickly, the state today of engagement in the US is pretty sad in the sense that a resident gets on average 11 minutes a day. And we see that as an opportunity, right? There's a big opportunity to advance our field. There's a big opportunity to help the staff engage the residents. And a lot of it has to do with what it is that we're trying to do and how we can improve and enhance what we do. And there's a lot of things to be said about how do we help the frontline staff, the resident engagement staff, do more of their quality work. One of the big drivers of this is to also understand why we're not investing more in this particular department. We sadly often joke about the fact that maintenance tracks more data and sometimes has more say in the operation than activities or life enrichment. And there's a lot to be said about the correlation between the work of an activity director or a resident engagement professional and its correlation with clinical outcomes and financial outcomes. When you look at the research out there, there is a fair body of evidence that says that if you engage residents in a person-centered manner, that will drive clinical outcomes, therefore financial outcomes. But that evidence isn't strong enough. And this is one of the reasons why Link Senior and its partner on the line today decided to invest in this to be able to advance the field by enabling and helping a stronger correlation between when I engage a resident, I am advancing, improving his quality of life, and therefore technically and hopefully also helping the business I work with drive better financial outcomes. There is some correlation depending on the type of interventions that we do. As you might remember, for the people on the line, on our previous webinar, we had a webinar about music and memory. But overall, as you can see from this slide, there is some level of evidence, but it is for the most part non-sufficient. It's insufficient. So this is why we're so excited to be able to share with you today our work with responsive management, Western Oregon University, with the generous funding of Baycrest through the CABHI program. I'll now let Dr. Ethan McMahan explain a little bit the study design, how we thought about what kind of outcomes we were looking for, how we orchestrated this, and I'll let him take over the next slide. Thank you.
All right. Well, thank you very much, Charles, and thank you, everyone, for having me today. As Charles mentioned, I'm going to be describing the study, or a great deal of the study that we have been conducting over the last year or so, examining the effect of recreational engagement, recreational activity on various aspects of quality of life in long-term care facility residents. And I first wanted to start off with kind of a top-level, very broad description of the study that we are conducting. And so the study itself really started when Responsive Health Management, or RHM, partnered with Link Senior, and then brought myself and one of my close collaborators, Dr. Rob Winningham, in to work on an innovative Center for Aging and Brain Health Innovation, or CABHI for short, grant that was funded through the Baycrest Foundation. And the project is part of CABHI's Industry Innovation Partnership Program, or what's called the I2P2 program. Now, for those of y'all who are not familiar with CABHI, it's a solution accelerator that helps drive innovations in the aging and brain health sector, and we are part of that. Our first of its kind partnership involves representatives from healthcare, from science, from industry and government, and is a hub for the design and development of innovations that help older adults age safely in the setting of their choice, while maintaining high levels of cognitive, emotional, and physical well-being. And so, in short, CABHI and our partnership with them is really geared towards facilitating the development of innovations that promote the well-being of older adults. So the I2P2 program is intended to accelerate the evaluation and adoption of innovative products and services that address the needs of aging adults and the specific challenges that are presented by an aging population. Now, to this end, we're conducting our study, the primary objective of which is to provide initial empirical evidence demonstrating the effect of both recreational engagement more broadly, but also linked senior use more specifically on various key quality of life indicators within residents and long-term care facilities. And so essentially we're looking at both recreational engagement, but also specifically recreational engagement that's facilitated through linked senior use, which is a software technology that's being used at RHM sites. And what we're doing in this study is we're comparing outcomes in residents that are using linked senior to those who are not using it. And we're also comparing those who are highly engaged in recreational activity versus those who are less engaged in recreational activity on these key clinical quality of life indicators. In addition to comparing these groups, we're also assessing degree of activity to determine if things like frequency of activity, duration of activity, regularity of activity, of recreational engagement is associated with more positive outcomes, or is there a dose-response type relationship? But this initial pilot, taken all together, is going to answer the question, does recreational engagement very broadly and linked senior use more specifically improve quality of life in these residents? And also, is degree of engagement or use associated with more positive outcomes? So if I were to summarize all of this, I would just say our overall goal or question is, does recreation have a meaningful, demonstrable effect on quality of life of residents in long-term care facilities? So speaking a little bit more specifically about the study design now. So the research study is using what we call a quasi-experimental repeated measures mixed design. So that's a very technical way of saying we're measuring multiple groups and we're measuring them at multiple times over an extended time frame. Residents at 2 RHM pilot sites, so these would be 2 RHM facilities, long-term care facilities, have been assigned to the treatment groups, so those who are using LEAP senior programs. And then residents, and after this point I'm going to refer to them as participants, at another site have been assigned to a control group, so those who are not using the LEAP senior program. Now, one of the things I want to point out is that all residents, regardless of the group they've been assigned to, are engaging in some degree of recreational activity to the extent that they can. However, these groups that we have set up refer specifically to those using Link Senior and those not using Link Senior. Now, this is a 12-month study. It's a 12-month multi-phase study, so it includes pre-treatment phases, treatment phases, and post-treatment phases. And during each of these phases, all participants are assessed on all key outcomes, which I'll talk about in a little bit more detail here in a minute, prior to the treatment phase. And then we assess them at regular 3-month intervals during the treatment phase. Now, the nice thing about this design, both the dividing individuals into groups and also measuring them at multiple times throughout the course of the study, is that it allows for the comparison of outcomes among Link Senior users and non-users, and also allows for the examination, the duration of the study allows for the examination of degree of use. Now, as I mentioned before, we selected participants from 3 different sites. Those sites were RHM Cedarvale Terrace Long-Term Care Home, Vermont Square Home, and the O'Neill Center. All of these sites are located in Toronto, Ontario, and each site has therapeutic recreational therapists on staff who are caring for mid to high level dementia residents. All staff have been trained, been GPA trained, and PCES trained. Now, just in short, I think it's probably helpful if we kind of keep some of the main, I'm going to present you with a lot of detail, but so we don't lose the forest for the trees, I want to hit some of the main points in short. So in short, what are we studying? Again, does recreational engagement promote positive outcomes and adaptive functioning in residents of long-term care facilities? That's the overall goal. Now, who are we studying? As I mentioned, we are examining residents or participants from 3 facilities in Toronto, Ontario, and currently the study involves over 200 participants or 200 of these residents spread across these 3 facilities. Notably, residents vary in terms of their age and their level of functioning, which we'll see in a little bit more detail here in a second. How are we studying this? And so this really gets at the research design that I talked about a little bit earlier. As I mentioned, we're using this multi-phase research design that's spread across a year. So the study, or at least the data collection, started in November of 2017. And our first pre-treatment phase, or our baseline phase, was conducted at that point. And then at every 3 months after that point, we've assessed level of recreational engagement, very generally, and also level of linked senior use, more specifically. And we've also assessed multiple aspects of psychosocial and adaptive functioning. As I mentioned, the study at least the data collection portion of the study is lasting 1 year. So starting in November 2017, data collection points occurring at 3 months along the way. So November, February 2018, May of 2018, August of 2018, and our last data collection point will be at the end of this month and occurring likely early in November. At that point, data collection will be terminated and we'll continue on to data analysis. Now, what are we measuring? So we're measuring recreational engagement. Obviously, if we're looking at the effect of recreational engagement, that's going to be one of the key things that we're measuring. And we're looking at participation in recreational programming and also linked senior activity more specifically. Now, one of the things that I want to point out is that we're looking at recreational engagement in a number of different ways. And so some of the data that I'll be presenting to you today operationalizes recreational programming or recreational engagement in terms of number of minutes. So the amount of time spent engaged in recreation or the amount of time spent engaged in linked senior-based activity. But we're also looking at recreational engagement in a number of other ways that would include the number of sessions engaged in, as well as the mean number of minutes per linked senior activity. And so we're going to be looking at activity from a number of different perspectives. Now, in terms of outcomes, we're looking at a lot of different outcomes. I've actually only included a subset of the outcomes on this slide. And these outcomes focus more on the clinical quality of life outcomes that we're interested in, but I want to point out the study is actually a little bit more broad than this, but we're going to be focusing on these outcomes today. So we're looking at cognitive functioning, which would include things like the resident or the participant's ability to engage in effective decision-making, short-term memory functioning, and so on. We're also looking at depressive symptoms. So to what degree do the residents engage in negative statements? Do they cry, and so on? We're looking at social engagement. So are they involved with their social environment? Do they feel comfortable in social interactions? We're looking at aggression, whether or not they engage in physical aggression, verbal aggression, are they resisting care, and so on. We're also looking at prescription medication use, looking at antidepressant prescriptions, antipsychotic prescriptions, as well as analgesic prescriptions. And in addition to focusing on the residents of these facilities, we're also looking at staff as well, looking at how staff are satisfied, the degree to which they're satisfied, and their attitudes based on how active their residents are. And so with that, I'm going to turn it over to Abby, who can tell you a little bit more about the responsive group and the day-to-day operations collecting data in this study.
Thank you, Ethan, and welcome everyone. I'll just give you all a bit of further background about responsive group, myself in regards to my day-to-day work that I do at Responsive, and also my participation in the study, as well as Marion, who unfortunately isn't here with us. So the Responsive group is a privately owned business, and Responsive is recognized as a leader in managing senior living environments, both in retirement and long-term care. There are 4 business units. The 3 homes that participated in the study are under the Responsive Health Management business unit. There is also the Responsive Management Incorporated, Lifetime Live-In, as well as Responsive Health Mentors Limited. Responsive also currently operates 14 long-term care homes, as well as 18 retirement communities in Ontario, providing hands-on approach in consulting, mentoring, and restructuring services. I'll just cover a bit about what Marion does within Responsive as the senior nurse consultant. quick overview. So not only is she responsible for the oversight of all clinical programs, best practice, and policy development, but also is a great support and works very closely with the therapeutic recreation department. Nursing and therapeutic recreation definitely goes hand in hand, so especially when it comes to dealing with residents that have responsive behaviors. There must be much collaboration between the nursing and the recreation staff towards antipsychotic treatment, which shouldn't always be the first choice. So nursing and recreation staff need to further collaborate, explore non-pharmaceutical interventions first. Furthermore, as a nurse consultant at Responsive, Marion was accountable or is accountable for compliance with the Long-Term Care Homes Act and regulations, as well as any other applicable legislative requirements such as Health and Safety Act, Public Health, and Ministry of Labor requirements. Marion also chairs the Joint Director of Care Committee and the Quality Council, where innovation and research studies such as the Link Senior and CABHI project are being shared and discussed. And one of her favorite responsibilities is to ensure that our residents in our communities are engaged in day-to-day activities that have purpose and have a sense of quality of life. I'll go into a little bit of what I do myself as the programs manager here at Cedarville Terrace. I oversee the day-to-day operations of the department. We have 4 recreation therapists and 2 rehab therapists in a 218-bed home. I ensure that the programs are implemented as planned. There's provisions of programs in all 5 domains, such as spiritual, intellectual, social, emotional, and physical, and also in compliance with the Long-Term Care Act. I ensure that all residents have been assessed and have an up-to-date plan of care that specifies their interests, as some of what Charles has spoken on, their likes, dislikes, the programs that they can be engaged in, and also a strong focus on interventions towards managing behaviors. So I also ensure, with collaboration with my staff, the program recreation staff, the creation of monthly program calendars, reviewing monthly reports, and development of action plans towards resident engagement in various areas. Some are, a big area would be resident at risk. So reviewing residents, making sure that they're all being engaged purposefully on a day-to-day basis. Self-directed activity, which is a key component for us, to ensure that residents are being provided independent activity supplies to explore and continue to live appropriate leisure lifestyles. Also evaluating, reporting, and consultation with the interprofessional team towards quality improvement plans, and especially reviewing, doing research to find and look at different studies that are innovative that we can participate in, such as this one. And also, when talking about person-centered care, we also look at our residents' council, our residents who come to these meetings, and the types of ideas, suggestions, recommendations, and even as an evaluation of the types of outings, new and old programs, participation, how we can get our residents to be further involved and live independent lifestyles, as well as being part of the interprofessional team to develop these action plans that we can look at the different program areas that we're mandated to work towards quality improvement in the skin and wound, weight loss, behaviors, pain, etc. So we look at different experiential programs that we can provide to our residents. For example, we have Bridget, which is not her real name, who is age 72 and enjoys craft, grew up in a farm environment, enjoys to have rabbits, birds, horses, etc. And in collaboration with the family, we're able to have the family donate feed for the birds and give this Bridget access to literature about birds, where she can further participate in self-directed activity of feeding these birds on a regular basis daily. Although we may consider it something that can be messy in our environment, but it's actually engaging her in a purposeful way, and she truly enjoys and looks forward to this self-directed activity. So if you look at some of the pictures that we have on the slides, providing sensory type of programs, a lot of reminiscence to continue to look at the things that our residents are definitely interested in and utilizing their knowledge and our knowledge that we have of them to further provide to them. For example, if we were to have a duckling program, as you can see in the picture, we would further utilize Link Senior to provide maybe sounds of ducks to increase the experience, and or videos of little ducklings playing in their environment as we are providing actual live ducklings in the home environment. So as we're working on the day-to-day of this Link Senior CABHI study, the programs department ensured that first and foremost received power of attorney and or self-consent from the residents to ensure that they understand through demonstration what Link Senior is, what our purpose of the study is, and what outcomes we're looking to achieve. The program staff are required to utilize the Link Senior platform as much as possible on a daily basis. And during the study, we ensure that there was a Link Senior program implemented each day, which also included having a kiosk on our main floor of our lobby that residents can access on an independent level. So on a monthly basis, we ensure that Link Senior programs are on our monthly calendar. We provided one-to-one programs, as I just mentioned, offered the kiosk so that residents who are able to be taught to utilize the kiosk, which is user-friendly, to be able to select music, games, videos, and various reading material on there as well. We provided small groups of residents of 1 to 4 where we engaged them in various topics. It could have been trivia on one day, and we also give residents the opportunity to select what program or activity they would like to participate in using Link Senior. We had 8 iPads on each in the programs department. One each was assigned to each community floor, and it was to be accessed by the frontline staff to have on a 24/7 basis. So we ensured that we provided training to our frontline staff, nurses, PSWs, and explained the purpose of this software and why we are using it. Program staff are to review the list of residents who have behaviors, who may be at risk of lack of engagement, have an increase in falls, different areas as mentioned by Ethan, to ensure that we are targeting those residents on a daily basis, encouraging staff to participate and engage with them using Link Senior. We even further went ahead and trained some family members and caregivers who are in the home on a daily basis so that they may have access by borrowing tablets from the programs department and with a process of returning it to us, so that when they are in the home, some family members are not aware of or sure of what types of activities or programs they can engage their loved one in, but using the Link Senior platform, they're able to have access to, as I said, videos, music, reading material. It can be spiritual. It can be something as painting and or even playing the piano on the Link Senior device. And it just simply helps them to have at least a toolkit of resources that they can utilize if they're unsure as to how to approach the situation. We currently have ongoing training that's provided in the home for residents who can use it independently, new staff at orientation, volunteers, and students who come into the home for various reasons, placement, and co-op, to ensure that they are able to have this resource available to them. And especially one of our students commented that from working in our home and going to another home, not having the Link Senior platform available made building rapport with the residents quite a bit more challenging. She found that having that as a device that she can use gave her an opportunity to be develop the residents and understand the residents' needs and interests and be able to further build relationships that way. The program staff review the most requested programs on a monthly basis. They track program participation. They receive suggestions and recommendations from residents and families to further request content on the platform directly from Link Senior. There's documentation, as I said, on engagement that's completed at point of click care. So utilizing the Link Senior platform, staff are able to, on the spot, be able to document who's participating, what's their level of participation, and whether or not they are engaged for the entire program on the spot, with an option that they can also do so using a dashboard following the program to further document. There is ongoing assessments that are completed for residents for their ability to utilize the tablets independently, to them utilizing it more frequently, and to also further increase their level of engagement. There is ongoing communication with frontline staff about the program preferences of residents to provide opportunities where frontline staff are able to engage residents using the Link Senior platform. And I will go into further looking at what Marion, as a senior nurse consultant, did on her day-to-day regarding this study. So Marion, as a senior nurse consultant, worked very closely with Link Senior and the Center of Aging Brain Health Innovation to get this study up and running. She was also responsible for getting the agreement signed, and that she is also the responsive health management project lead for this specific study. She worked closely with my team at Cedar Vale, as well as the other teams in the two other home participating. She ensured that all the homes have the necessary equipment, so the mobile devices, the tablets, Wi-Fi connection, etc., for the project, and worked closely with the IT department to ensure that everyone had access and was set up. Marion also participated in the biweekly update calls, which as well, and the other teams, to try to further motivate and support the team wherever possible and wherever needed. Marion also assisted with data collection, made sure that the homes were collecting the appropriate data and ready for the data submission that happened on a quarterly basis. And together with myself, assisted with completing our quarterly reports to be submitted to CABHI, as well as sharing with Link Senior. And Marion is currently also responsible of ensuring that the financial reports are submitted in a timely manner to CABHI. And I believe Ethan will share some further research results.
Yes, so thank you, Abby. I appreciate that. So I'm back now to tell you a little bit about what we found. Now, one of the things that I want to emphasize about these results that I'm about to present to you is that this study, as I mentioned earlier, data collection is ongoing. We haven't completed data collection yet. And so what I'm going to present to you today is actually just a subset of some very initial preliminary findings that address the major research questions of this study. And then once we complete data collection and have a chance to look at the data more thoroughly, we're going to have some additional results. But again, the stuff that I'm presenting today, just some initial preliminary data that addresses the question that we talked about earlier, and also focuses primarily on some of the clinical outcomes, the quality of life outcomes that we were interested in. As I mentioned, we're looking at aspects of functioning and aspects of recreational engagement beyond just the effects on quality of life in residents, but these are going to focus very specifically on quality of life. And so the first thing I want to go over is just some demographic and descriptive information for the residents in the study. Now, note at this point in the study, we have collected data from 254 different residents, or 254 participants. Now, I want to point out that for any one analysis that I'm about to present to you, they're not going to include, or that analysis is not going to include all 254 of these participants. So what we saw throughout the study is that some people would start the study and then they would drop out of the study. Some people would not start the study until later phases. Some people would fill out certain assessments, but not other assessments. And so the point I'm trying to get across is that even though we have a good large sample here, not each of these analyses is going to include every one of those 254 individuals. But in almost every single case, for every single analysis, we have more than 200 participants, so that's more than enough to run the analysis in question. Okay. In terms of demographic information, as you might imagine, with this type of sample, we had more females than males, so 167 females, 72 males, 15 individuals did not disclose their gender. In terms of age, so the average age is 81.91 years. However, as I mentioned earlier, the sample is quite variable in terms of age, and so the youngest individual is 50 years old, and the oldest individual is 103 years old. And then in terms of the number of participants that are coming from each of the different facilities, the most participants, at least of the 3 facilities, came from Cedarvale Terrace, the 115 residents participating there. Next, we had 93 residents participating from the O'Neill Center, and then 44 residents participating from Vermont Square. Now, in this table that I'm presenting down at the bottom of the slide, this is going to list out the major variables that we're interested in for the set of analyses that I'm going to be presenting here shortly. And what we're listing out is recreational engagement. So this is going to be the number of minutes involved in recreational engagement over 270 days. And so in this set of analyses, we're actually including all of the data aggregated over multiple waves. And so this figure right here would be number of minutes over 270 days. So the across the waves that we've collected data from so far. Here we have linked senior use. This is going to be the number of minutes over 270 days that were dedicated specifically to activities related to linked senior. And those are our 2 primary predictor variables, or the variables that we're interested in examining the effect of. So we're interested in examining the effect of engagement in linked senior use. The remaining variables are going to be what we would call outcome variables, or those variables that we think are affected by recreational engagement or linked senior use. And again, I mentioned we're going to be focusing on the clinical variables for this presentation. And so we looked at cognitive dysfunction, depressive symptoms, social engagement, aggressive behavior, number of antidepressant prescriptions, number of analgesic prescriptions, and antipsychotic prescriptions. Now, in terms of each of these scales, cognitive dysfunction was measured on a 0 to 6 scale, with higher scores indicating higher levels of cognitive dysfunction. Depressive symptoms were measured on a 0 to 14 scale, again with higher scores indicating higher levels of depressive symptomology. Social engagements measured on a 0 through 6 scale, with again higher scores indicating higher levels of engagement. Aggressive behaviors measured on a 0 to 12 scale, with higher scores indicating higher levels and more frequent aggression. And then as far as the prescriptions are concerned, these numbers represent the number of prescriptions prescribed to an individual over the 270 days, okay? And so that one's very, very specific. The cognitive dysfunction, depressive symptoms, social engagement, and aggressive behavior subscales, these all come from the RI-MDS assessment, which is a validated measure of quality of life and functioning more broadly that's typically used in these types of facilities. All right. So what have we found so far? So I'm going to present you with two different sections of results. The first of which is going to focus on the relationships or the correlations between recreational engagement and linked senior use and some of the outcomes that we have described. And I'm going to first focus on general recreational engagement. And what we found in the study so far, again, across all of the waves of data that have been collected, is that increased recreational engagement is associated with, first, lower cognitive dysfunction. So in general, as individuals are more engaged, the lower their levels of cognitive dysfunction are. We've also seen that increased recreational engagement is associated with decreased general aggression. So the more engaged individuals are, the less aggressive they tend to be, the less incidents involving aggression we tend to see. As you might imagine, the more individuals are engaged in recreational activity, they tend to show higher levels of social engagement, a very strong relationship here. So as recreational engagement goes up, so does social engagement. And then we've also found marginally significant negative trends between recreational engagement and the number of prescriptions that individuals receive, specifically for antipsychotics. And generally what this is indicating is that as recreational engagement goes up, number of antipsychotic prescriptions to a given resident tends to go down. So that set of findings concerns general recreational engagement. Now let's talk a little bit more specifically about linked senior use. And so using the linked senior software, the linked senior platform as a way to administer or to implement recreational engagement. And in this case, we found that increased use of linked senior is associated with decreased general aggression at a level that's comparable to what we see with the general recreational engagement. So again, as linked senior use goes up, engagement in aggressive behaviors and just general aggression tends to go down. And we also see higher levels of social engagement associated with linked senior use as well. So as individuals become more engaged, more using linked senior more, we tend to see higher levels of social engagement as well, which is pretty interesting considering that linked senior is this, it's software, it's electronically mediated recreational activity, yet at the same time, it's encouraging social engagement. Now, my colleagues at Linked Senior and at RHM often point out when I present findings like the ones I've just presented to you, that they're a little bit hard to interpret, that they're not quite sure what that means. In one sense, it's very easy to understand in the abstract, as one variable goes up, another one goes up, or as one variable goes up, another one goes down. So it's easy to understand that as engagement increases, cognitive dysfunction decreases. But at the same time, the question is there a way to present these findings in a more tangible fashion, an easier to understand fashion, something that's a little bit more actionable? And so what I've done is I've created some comparisons. And what we're going to do is we're going to compare individuals who are highly engaged in recreational activity to those who are less engaged in recreational activity on all of our outcomes of interest. And when we do this, we find that when you compare those who are highly engaged to those who are low, who engage in less recreational activity, we see that there's a 3% decrease in cognitive dysfunction among those who are highly engaged. We also see a 20% increase in social engagement among those who are highly engaged in recreational activity versus those who are less engaged in recreational activity. We see an 18% decrease in aggression among those who are highly engaged versus those who are less engaged. And we also see a 20% decrease in antipsychotic medication use among those who are in the high engagement group versus the low engagement group. And by framing these differences in terms of percentages, and one of the things I want to point out is that really we're looking at the same thing that we were looking at on the previous slide, except now we're conceptualizing the effect of engagement in terms of percentage differences rather than relationships. When we look at linked senior use specifically in a similar fashion, we find that among those who use linked senior quite a bit relative to those who use it less, we see a similar decrease in cognitive dysfunction, so a 3% decrease there. We see a 12% decrease in depressive symptoms among those who are using linked senior at a high level versus those who are using it less. We see an 11% increase in social engagement among those who are using linked senior at a high level. And we also see a 9% decrease in aggression among those who are using linked senior at a high level versus those who are using it less. Now, what does this all mean? So some tentative conclusions from these initial preliminary results. Recreational engagement, as shown on the previous two slides, seems to be associated with several positive outcomes. Those who are more engaged in recreation, broadly speaking, and also in linked senior more specifically, seem to do better across a number of different outcomes that we're measuring. And so this recreational engagement or getting involved in this activity may be a route to optimal feeling and functioning within these long-term care environments. Where do we go from here? Well, I want to emphasize that this is an ongoing study. We're still collecting data. This is just the beginning of us looking at this data and seeing if recreational engagement has an effect. And so as we wrap up data collection, we will then take a look at the additional waves of data that we're going to collect, but also engage more sophisticated and more complex analyses that can address the effect of recreational engagement and linked senior use in a more comprehensive and nuanced manner, with the goal being to provide a comprehensive scientific assessment of the effects of recreational engagement. And with that, I will turn it back over to Charles, I believe, to wrap things up.
Yes, thank you very much, Ethan. Also, thank you, Abby, for discussing your work and your work on the study, and also for covering Marion, who unfortunately cannot be there today. I think that one last final statement is for all of us involved in this field of resident engagement. What we do today really is all about our resident, all about the older adult that we care for, and how we can drive person-centered care and drive quality of life. And I think that the word purpose really fulfills a lot of what we're trying to cover, which is how do we advance the field and how do we make sure that engagement is more highly correlated, there's a stronger link with quality of life and purpose. With that, I'll turn it over to Megan to see if we have any questions and wrap up with final administrative details.
Thank you, Charles. We do have one question to the panelists, which is, can you name some ways in which these findings are going to really advance the field of recreational engagement for residents?
Yeah, I can take that question. So I think I'd like to refer to what Abby was saying previously, which is that sadly enough, often we, as organizations, we tend to look at medication as a way to cure and cover everything, what our residents need. And I think that we all know that, for example, music or engagement or activity makes sense. But I think that this kind of study helps us draw a stronger link so that we can consider, instead of prescribing medication, consider one day prescribing, for example, music or reminiscing or some of the things that we do. And I think that the reason for that is I'll share a story that happened to me a few years ago when I was at an activity director conference, and one of the speakers was asking the audience, raise your hand if your budget per month per resident is X, and so on. And there were people in the room that weren't raising their hand until the dollar amount per resident per month was $1. Right? So I know that most of the industry now is higher than $1 a resident a month. But still, I had a neighbor of mine that did not raise her hand at all, and she was actually shy to say that her budget was under that. And I think that the reason why we still have this situation, and the reason why we have less budget in this particular field, is that as a life enrichment coordinator, as an activity director, or sometimes a rec therapist, it's very difficult for us to articulate and show a strong link between the quality engagement we do, the quality of life that we help enhance, which in turn would correlate with financial outcome for our organization. And I think that this kind of study, with the amount of details that Dr. Ethan McMahan presented, I think is exciting, because not only does it help us prove the quality work that we do has an impact, and also further kind of pushes the envelope further for our discipline. I don't know, Ethan or Abby, if you have any comments on that.
Yeah, I guess just if I could add one thing, and it's just building off of something that Charles mentioned, is I think a lot of folks have an intuitive understanding that things like music therapy and art therapy and recreational engagement, that it has these positive effects. But in order to make real substantial change for things like policy, or for facilities to adopt these practices, you need tangible research results. You need empirical results that are going to show, with a great deal of evidence, that these things have an effect. Intuition and anecdote provide some evidence, but the strongest evidence comes from science. And so one of the nice things about this type of study is that by having these results and saying that recreational activity has these effects, and we know this because we examine this in this fashion, I think it makes a stronger argument towards for a movement towards using these alternatives to pharmacological therapy in these facilities.
Thanks a lot, Ethan.
Okay, well, we are coming to the end of our time together. We have about one more minute here. I have put up on the screen the contact information for today's speakers and panelists. Please reach out to them if you have any questions or comments. The required survey for today for CEU credit is now in the chat box. You can click that link to go directly to the short survey. In the handout section of the webinar room, there is also a PDF copy of today's slide deck for your convenience. And I'd just like to remind everyone about two upcoming webinars. The first is on November 15th with Vicki DeClercq-Rubin, who is the director of the Validation Training Institute. NAB and NCAP CEU credits will be available for this webinar, as well as for the webinar with Jennifer Brush, who is doing Montessori for aging and dementia. We hope you can join us for both of these webinars. Registration links will be sent via email. They're also available on our website, and you will be receiving a copy of the recording of today's webinar as well. So we hope to see you on November 15th, and thank you everyone for joining us.
Thank you, everyone. Have a good day.
Thank you.